I think we all are very happy, if the baby is born like this, crying, pink. Yeah, but sometimes our dream may turn into a nightmare if a baby is born like this, Down's baby, very bad cleft lip palate, a baby with a heart disease. This is a child, sleeping with the blood transfusion going on. And this is an albino child. So these are not very uncommon. Congenital malformations occur in about 2 to 5% of all pregnancies, of which 0.5% are chromosomal abnormalities. And then we have the single gene disorders. And all these birth defects are defined as structural, functional anomalies, hereditary disorders, which are developed during intrauterine life, but identified mostly at birth or much later after birth. It is very interesting to note that now, with the advances in science, some of them are very, very preventable. We can prevent the birth of a baby with a chromosomal abnormality like Down syndrome, with thalassemia major, with Duchenne's muscular dystrophy. This is a child with hemophilia. This child cannot play because if he falls, he will bleed, and this will lead to this problems. And these are hereditary conditions, so they can be very easily picked up. There is a very good chance that their offspring will be normal. So, we have to think positively and counsel that we can have a normal baby, but an abnormal baby can lead to problems not only to the family, but to the child. Spinal muscular atrophy, Duchenne's muscular dystrophy, just look at the very, very enlarged thighs, but this child cannot walk. Then we have conditions like osteogenesis imperfecta, single gene X-linked disorders like Fragile X syndrome is the second commonest cause of mental retardation in boys. Then we also have lethal skin disorders like epidermolysis bullosa dystrophica. This multifactorial reason, the spina bifida is the commonest cause of life on a wheelchair. Then we have conditions which are maternal conditions which can cause problems in the baby like rhesus isoimmunization. Then this lower down picture, this is a child born with congenital rubella syndrome, which may lead to keratopathy and blindness, hearing loss. So all these conditions may occur. So in this era, when we are going to the moon and Venus, is it not possible to prevent the birth of a baby with a handicap? Prenatal diagnosis and therapy has been started, almost 30 years back, and more conditions can now be done. So the fetus has been given the status of an individual, the status of a patient. It is no longer an appendage of the mother. And with the control of diarrheal diseases, these malformations and genetic disorders are coming up more as more important causes of fetal neonatal mortality and morbidity. Life begins at conception, not after birth. At birth, it may be too late. There may be more than 4,000 diseases that can affect the fetus. And as I said, at birth, it may be too late to go back and treat. And these defects can cause serious mental harm, economic burden on the family, the society, and the healthcare system. Also, if you obstetricians, in your hands, you have a baby born with Down syndrome, or thalassemia, you may be sued. So legal issues are also there. So there is a need for specialized care for fetuses at higher risk of chromosomal anomalies, congenital malformations, congenital infections, genetic and syndromic diseases, IUGR, and now fetal medicine is one of the most rapidly evolving fields of obstetrics and medicine. In fact, the 21st century obstetrics is not without fetal medicine. It is the state-of-the-art obstetrics and perinatology. Now, what is the team, fetal medicine team? The fetal medicine specialist is obviously the team leader, but the obstetrician looking after the high-risk pregnant woman is the very important person. Then we need cytogenetic molecular geneticists who will run the genetic laboratory. We, of course, the specialists are also ultrasonologists, but we do have MRI cardiologists who can do the specialized fetal echos. We do need microbiologists, neonatologists, and depending upon the case, the pediatric neurologists, nephrologists, and so on. At the same time, in all my 35 years of practice in fetal medicine, I have interacted with a lot of social groups, thalassemia welfare societies, hemophilia societies, Down syndrome societies, and they are very, very important part of the fetal medicine team. Now, my most important slide, the role of the obstetricians. The role of the obstetrician is not to be a geneticist, but they must have a knowledge, a running knowledge about how to take a 3-generation family history for genetic disorder. I don't know how many of you take this, a genetic history, of 3 generations. All you have to do is ask whether your auntie, uncle, mother, father, cousins, anybody has any genetic disorder. And then you have to plot it on this pedigree chart, which shows the 3-generation family's history. You need to identify and screen all mothers for high-risk pregnancy. All mothers. When I was delivering lectures, people used to say that if the first baby is normal, then you don't have to screen the second baby. Is it true? No, not at all. Each and every pregnancy is important. You need to screen them. And the obstetrician is the person who first meets the patient, pregnant woman. The first line counseling for the specific disease, prognosis, options has to be made by the obstetricians. And most importantly, after they have picked up something suspicious, something risky, they must refer to the fetal medicine specialist on time, because you still know that termination of the pregnancy, if we need to do, cannot be done after 24 weeks now, not yet. So it's very, very important for timely referral. And then while all these procedures and treatment is going on, the follow-up of the maternal and the fetal monitoring has to be done in collaboration with the fetal medicine specialist. We have to time the delivery and we need expert neonatal care. At the other side, what is the role of the fetal medicine specialist? A fetal medicine specialist is one who has undergone advanced training beyond the postgraduate obstetrics and gynae. Most often it is fellowships, like I have trained in USA, UK, because there was no training in India at that time. I'm talking about the early 90s. And but now we have a lot of training centers. I was very interested to start DM, but because it has still not picked up very well, there are no jobs as yet. So we are going steady. We have fellowships now. So the fetal medicine specialist must know about the maternal fetal syndromes, the biochemical disorders, molecular cytogenic genetics. They should be able to counsel the pregnancies for this pregnancy, the index pregnancy and future pregnancies. They have to be expert at interpretation of the screening tests. Obstetricians may sometimes face a problem whether to do amniocentesis or to do not just reassure them or to advise an NIPT. So this has to be done by an expert. And then the fetal medicine specialist should be able to do the prenatal diagnostic procedures like targeted genetic ultrasound, diagnostic procedures like amniocentesis, CVS, chordosynthesis, fetal liver, kidney biopsy, fetal autopsy, and where necessary, they should be skilled in fetal therapy. There is medical therapy, drugs, intrauterine fetal blood transfusions. There could be surgical therapy, fetoscopy, radiofrequency ablations, shunts. Then we have complicated twins, so fetal reductions, all this. And very, very important is research. Every day, new things are coming up. Gene therapy, innovative fetal surgery, PGS, PGD. So a research is a very important component which the fetal medicine specialists have to do. Now, going back to each stage of pregnancy, I would like to talk about when the obstetrician needs to refer a case to the fetal medicine specialist. Pre-pregnancy or the preconception high-risk factors. You don't have to say all cases, but certainly women above the age of 35, subfertility, recurrent miscarriages, they need expert advice. If there's a personal or a family history of genetic disease, if the parents have a balanced translocation, previous child with Down syndrome, thalassemia, Duchenne's muscular dystrophy, anything, or during pregnancy, pre-pregnancy, you find that the mother or the father has come a thalassemia screen positive or has sickle cell disease, then you have pregnancies with high risk for fetal outcome, like very severe diabetes, or the woman has had exposure to drugs like, warfarin, congenital infections. The patient has conceived after having a hysterosalpingogram in that pregnancy. And of course, a large number of my patients are Rh isomalized. So these are the various things that you can diagnose pre-pregnancy, which needs the expert advice of a fetal medicine person. You all know these charts, how maternal age increases the risk of any chromosomal abnormality, whether it's trisomy 21, 13, 18, or the X chromosomes. Then you have the woman coming to you in the first booking, you have done investigations, the obstetrician does the routine, the double markers, they advise them about the ultrasound screen about 11 to 13 plus 6 weeks. This has become quite routine for obstetricians. But when there is a problem and then there is a need for doing an invasive technique, you need to counsel because you don't know what is going to be the risk, what is going to be the outcome. Then you need to refer to the fetal medicine specialist. Complicated twins, you do get a high levels of TSH, very high, then APLA, other maternal reports. Then you get a first trimester diagnosis of the query chromosomal abnormality, because all structural abnormalities are not associated with chromosomal abnormalities. Some of them are. So do you really need to do an amniocentesis, or carry on the pregnancy and have the neonatal surgeon look after it? Or do you have to do something during pregnancy because the organ failure can occur? This can be done only by the fetal medicine specialist. Also, if there is early growth restriction, severe oligohydramnios, severe polyhydramnios, and certainly Rh abstinence pregnancies. So all these need to be referred to the fetal medicine specialist on time. If a woman has not been detected in the first trimester, then, comes the second trimester problems. Positive quadruple marker, people are still doing triple marker. They still do, of course, you do a lot of cases where you get high risk NIPT. Then you have structural malformations of various organs. You need to know whether there could be an associated chromosomal defect, whether there could be organ failure, or you can carry on till term. Sometimes you get conditions like, borderline hydrocephalus. Then you get some other conditions where you're not sure what to do. Those are cases that needs to be referred. Now, there is another thing called syndrome. And this syndrome is a constellation of at least 3 clinical findings. And they are not chromosomal. They are like Zarko-Levin syndrome or so many Hunter syndrome, other syndromes that can be there. And of course, congenital torch infections, they're still there around and can cause problems and in the interpretation and in the management. So this is one slide which I have been teaching for the last 30 years and which have been upgraded. I just want obstetricians to look at this. 10 weeks is the ideal time for double marker, not 13 plus 6 weeks. I know a lot of people are doing it, but the best time is 10 to 11 weeks. And the best time for doing the ultrasound is actually 12 weeks. So a lot of people do them together. And then, because it can make a difference, and on the fetal medicine specialist will be able to understand that. Quadruple marker, if you have not done a first trimester screen, then you need to do And that again should be done at the appropriate time. Ultrasound for targeted anomaly, aneuploidy, screening for preeclampsia. That is very, very important now. You can predict preeclampsia, you can predict IUGR, preterm labor. I'm happy that I can say preterm labor because you can predict it. And of course, you may have to do ultrasounds later on in pregnancy if there are certain clinical features. ISWOG has said that, first trimester screening should be advised to all pregnant women because 90% of abnormalities occur in low-risk population. Then maternal biochemical screening tests. These are screening tests which are now almost routine. You do the combined test, which is the best one, along with the NT. And of course, if the patient doesn't turn up, you do it in the second trimester. Then comes the ultrasound screening in the first trimester. This was the work that I had done in the early 80s, where you could actually see the spine as early as 12 weeks of pregnancy, could pick up, a cystic hygroma, could pick up a very big bladder. So we could pick up a Turner syndrome as early as 12 weeks of pregnancy. I think obstetricians should need to know that what is the significance? What is this, percentage of detection with NT? And the best seems to be the NIPT. Then second trimester ultrasound, the fetus is a little bigger and you can detect more things like duodenal atrachas, kidney disorders. Then with things like three-dimensional ultrasound, you can, the three-dimensional ultrasound picture almost looks like the fetus which has been aborted thanks to the prenatal diagnosis. Then we have certain things like echogenic cardiac focus, choroid plexus cyst, echogenic bowels. All these are markers which point towards a chromosomal abnormality. And now recently we have the non-invasive prenatal cell-free fetal DNA. We used to do fetal cells, but we are now relying more on the cell-free NIPT, where you can see that it has a very, very good screening, rate, but it is still a screening test. It is not a diagnostic test. So when to do NIPT, how to interpret NIPT, you need the advice of the fetal medicine specialist. Then, is NIPT useful in twins? That again needs to be checked. And there are lots of reading in between the lines. You get a diagnosis of malformation. Is it associated with a congenital malformation? Is it associated with a aneuploidy? Again, the fetal medicine expert will tell you what is the risk of a chromosomal abnormality with duodenal atracha, with clubfoot, diaphragmatic hernia, so on and so forth. And then the fetal medicine specialist should know how to do prenatal diagnostic invasive techniques, amniocentesis, chorion villus sampling, cord blood sampling, the period of gestation. You cannot do amniocentesis at 14 weeks. You cannot do CVS less than 10 weeks. And you cannot do cord blood sampling before 18 weeks because the cord is very small. Again, skin biopsy not below 22 weeks because the skin is not formed. So this deeper knowledge is only with the fetal medicine specialists. And of course, you need to counsel the fetal loss risk with each procedure. The other day, somebody came to me and said, amniocentesis nahi karna hai, there's a 50% risk. I said, no, not 50%, it is 0.5%. So, you need to tell what is also the background fetal loss. Because you just can't say it straight away like that. You have to take the case in mind. You have to see what actually are the problems, and then you have to come to a figure. Amniocentesis, we are doing for many indications for chromosomal abnormalities. And I will share the screen if it doesn't. It is done under all aseptic and antiseptic care and under continuous ultrasound guidance, A very fine needle is inserted. You have to look, this is a magnified view, you have to look for a place where you can avoid the placenta. I can see there is a pocket here. So using a 22 gauge needle under the continuous ultrasound guidance, we push it in with a sharp jerk. Otherwise, the membrane will tend. And then it goes into this, avoiding the fetus, avoiding the cord. We take out the stellate, we withdraw the amniotic fluid, and then we send it for the required investigation. We do fluorescent in situ hybridization, or we do culture, and then we check the fetal heart activity at the end of the procedure. Very good fetal heart activity. Then we have Coren-Villa sampling. You can see this is the placenta. And here the needle, 18 gauge needle is inserted into the placenta. And at the same time, suction is being done so that the villi are aspirated, and you do it. This is an 11 weeks fetus, so you have to be very, very careful. And this is the villi, which is branching. You have to differentiate from the decidua and then send it. We can also take blood from the umbilical cord, from the umbilical vein, and for various indications, as I showed here. And here we just paralyze the baby, especially for longer procedures, by giving vacuronium. This is a needle in the baby's deltoid. This is a 18 weeks pregnancy. We are taking, the needle is inserted under ultrasound guidance. This is a vein, and the baby is pushing. We're waiting for it. Yeah. With a sharp jerk, the needle is inserted into the vein. The stellate is withdrawn. This is with color Doppler that we are seeing. And we take about 3-4 ml and check the fetal heart activity at the end of the procedure. This is my data of 1,342 chordosynthesis done by 2012 for various indications. Most of them was RH isomnization, karyotype, biochemical screen, IUGR, symmetrical IUGR, congenital infections, and so on. It is sometimes you may have problems because of, 2 cesarean scars. If the placenta is posterior, you can't do severe excessive movements. But most important is operator experience and training of the fetal medicine specialist. You need a very good laboratory, cytogenetic laboratory, molecular laboratory for DNA based. I'm going quickly because I have less time. Please let me know when to stop. Dr. Varshne. Now, fetal medicine specialist needs how to do fetal therapy. And this is a very small group where if you do not do fetal therapy, the baby will have organ damage. Medical therapy, digoxin, amiodarone, steroids for fetal lung, thyroid drugs, parvovirus infections to be treated by spiramycin. Look at this heart. This is a case of bradycardia. This is a AV block. And you can see there is pericardial effusion. We have successfully treated this patient by giving salbutamol, and we have given steroids because the mother had anti-Rho, anti-La antibodies. This is a case where you can see there is so much, supraventricular tachycardia, where we have saved the baby. You can see there is effusion, baby is having cardiac failure. And we have saved the baby by giving Fetal in collaboration with the cardiologist. RH isomnization, 400, 500 gram baby will die if you do not give blood transfusion. There is hydrops already. And we used to get a lot of cases with hydrops. But now, because we are telling them that as soon as you find ICT positive, refer so that we can do diagnosis early, do therapy. So people are sending them to us. Okay, I'll show you the video. And this is my data of so many cases where our success rate is more than 98%. This is almost at par with the best centers in the world. Also, we are finding that patients are being referred more and more without hydrops because the outcome in hydropic versus non-hydropic is worse. So we want babies to be referred to us in the non-hydropic. Then comes fetal surgery. This has evolved over the years. You know, people used to do hysterotomy, take the baby out, do the surgery and put it in. Obviously, when I was in San Francisco, there was a 50% preterm labor rate. So now we have lesser procedures called image-guided surgery and endoscopic surgery. We do, of course, fetal reductions. This is one, I think a lot of you, this is a twin pregnancy. We are going to put in a needle because the mother did not want twins. So this is at 14 weeks. Under ultrasound guidance, you can see the needle going straight into the heart with a sharp jerk. The needle is in the heart. And now we put in potassium chloride and the baby's heart stops. In posterior urethral valves, in pleural effusions, we may need to put in a shunt. So it is a double pigtail catheter which we insert. So one end is inside the bladder or the pleura and the other one is outside so that the fluid will come out. Otherwise, the kidney will be damaged. And this is one case where I'm showing you, that you need a double pigtail cannula, which we are going to see. We do amnion fission because there is no LICA. So the needle is here and we are putting in fluid because the bladder is now functioning. And now under local anesthesia, we will put in the trocar. And this is the Harrison shunt. It's a double pigtail shunt. Urine will flow from one end to the other end. We give a sharp nick with the knife and then we put in the trocar. Then after that, we feed into the trocar this shunt and we go in. All this is done under ultrasound guidance. This is the introducer, which is about 3 millimeters. This is the trocar, which is going to go in, through which we will put in the Harrison shunt. And this is done, you can see under ultrasound guidance. Here, the trocar has entered into the bladder. We will take it out and push in the shunt. Half the shunt will be inside and half the shunt will be outside. We have paralyzed the baby so that it doesn't move. Now the shunt has been introduced. And you can see the shunt is halfway pushed into the bladder. And after which, when we know that one loop has gone there, we will take it out so that the other half is outside the bladder. Now we can do laser ablation of a CCAM. Here you will find that this is a cystic adenomatoid malformation of the lung. Look at the lung. The lung is solid. This lung will not be able to breathe. It has pushed the heart to the corner. So I am pushing a laser fiber under ultrasound guidance. You can see that this is my needle, which is carrying the laser tip, and it is going into the lung. And with that, I will push the current, the laser current, and this will cause autolysis of the thing. You can see the heart is still beating there. And now I'm pushing in the laser current, which is going to autolyze this, after which I will take about 4 or 5 points and push it in. So this is how, and this case, after 2 weeks, when we did ultrasound, there was no lesion. And the pediatricians did not believe that there was a CCAM. Then we have radiofrequency ablation, where we can put in a needle and, just ablate the umbilical cord. When there is a monozygotic twin, you cannot do KCL. Then came endoscopy. And here we use very fine instruments. And in Delhi, in India, I was the first one to start laser treatment at AIIMS in 2011. This is a twin-twin transfusion syndrome. If you don't do anything, both the babies will die. You have the oligohydramnios and the polyhydramnios sequence. And what you need to do is push in the laser so that you divide these connecting vessels and divide the placenta into two. So this is the laser fetoscopy, which you can see this is at around 18 weeks of pregnancy. The fetal nose, skin is not formed. And you can see that, and I'm coming to the point where I am looking at the AV connections. You can see here the amnion, which is saying, and these are the connections. So the laser tip is now coagulating the vessels. You can see, I'm fast forwarding because I think time is going, and you can see this vessel which has been ablated. So this is ablation of the vessels which are communicating vessels. We have done a lot of cases, and the outcome has been almost 90% success. These are invasive techniques, and some of the complications are bleeding, preterm labor, PPROM. So we have to be very careful about all this. We can also cut amniotic bands with the laser. And what we still haven't done it, but we can treat congenital diaphragmatic hernia by plugging the lungs. Then we have a very interesting cases where we do exit, ex utero intrapartum treatment, where we actually deliver only the head. We do the treatment of the fetus while the placenta is still inside. And this was a case where the neck, this was a case referred to me by Apollo Hospital, and there was a very big neck mass, which was a teratoma, and you will see that we could not do anything, but we delivered the baby's head. TSH was normal. Here I must appreciate the anesthetist. Now, can you look at the tumor in the neck? Only the head is out. The anesthetist has given such good relaxant that the placenta is not going to come out. And now the anesthetists are intubating the baby. Otherwise, the baby will die. They have not been able to intubate. It was so difficult that they actually did the placenta is still inside. And now the ENT surgeons are going to do a tracheostomy. So they have done a tracheostomy, and then they managed to intubate the baby. So I'm rushing because I think my time is up. So I must say that there are lots of things which are still experimental, which are still coming up, but fetal treatment is something which is in the horizon. More and more conditions are being amenable to treatment, and the research and enthusiasm is going on. I must thank Professor John Quinan and Sacker, with whom I did my WHO fellowship, and of course with Professor Kypros Nikolaidis, with whom I did my ICMR Senior Scientist Fellowship and learned fetoscopy. Thank you all very much.